Good morning. If people can take their seats. My name is Nizar Jarjour. I'm the division head for allergy, pulmonary, and critical care. And on behalf of Dr. Page, who couldn't be with us today, and the Department of Medicine, I welcome you to our grand rounds. This morning, Dr. Samir Mathur is going to be presenting us a talk on the dawn of a new age of asthma management, the phenotype-specific therapies of severe asthma. Dr. Mathur is one of our very own. He's an associate professor in the Department of Medicine, Division of Allergy and Pulmonary and Critical Care Medicine. Let me give you a brief background about Dr. Mathur. He earned his bachelor's degree in science and biochemistry in 1990 from the University of Illinois, Urbana-Champaign, with high distinction. He went on to join Northwestern University MD-PhD program, earning his MD in 2000 and his PhD in biochemistry, molecular biology, and cell biology in 1999. After that, he took a short research fellowship at the University of Illinois in the year 2000, and we were lucky to recruit him to his fellowship in allergy after his residency at Loyola University. He spent 2003 to 2005 as a fellow in allergy, pulmonary, and critical care, earning allergy and immunology training, and going on to do 2 years as a clinical instructor in the division 2005 to 2007. After that, he remained on the faculty as an assistant professor, earning tenure in 2013, and has been an associate professor in the division since 2013. Samir has had a very productive career so far, currently leading an NIH-funded R21 on eosinophil biomarker in esophagitis. He's also has an investigator-initiated industry-funded grant looking at the use of omalizumab for urticaria, and he's also a lead for our laboratory core in the program project grant that is investigating the role of eosinophils in asthma. He has also had several other awards, including R21, as well as funding from the Academy of Allergy, Immunology, and Asthma, and funding from the T. Franklin Williams Scholar Program. His honors are many, so I'm going to just limit it to a couple honors here. One of them is from the Department of Medicine, including the Department of Medicine Bestow Research Award, which is given to a junior faculty accomplishment in research in the year 2010, and the Respiratory Disease Young Investigator Forum for a Junior Faculty Award in the year 2006. Samir has had a number of roles that involve leadership at the national level and local level. Locally, he is our lead program director for allergy since 2015. He directs the allergy program at the VA hospital, and he is our clinical service chief for allergy pulmonary, allergy and immunology. He is a past president of the Wisconsin Allergy Society, and he is also has served on the Academy of Allergy Committee on Aging. Samir continued his service locally for the IRB, as well as on the Department of Medicine Post-Promotion Committee and IT Committee. He has a number of teaching engagement at the medical school and the Department of Medicine, and his research has resulted thus far in 43 publications. So he has got a number of accomplishments both in research, clinical, as well as teaching. So it's a pleasure to introduce Dr. Samir Mathur to talk to us about the dawn of a new era in treating asthma. Samir?
All right. Thank you, Nizar. All right, so I'm not sure if other speakers have done this before, but I'm actually going to try using some interactive polling in my talk. Now, I have the basic subscription to this, so I can only have 40 people respond. So I'm going to actually ask that anybody that's doing asthma research or is in the allergy or pulmonary divisions not answer the polls, but all the rest of you should answer. And so basically all you have to do, as is outlined here, is use your smartphone. That's probably the easiest way. There's that number, the 37607, and then you have to text this long, my name and 667. And then after that, I think it asks you one other question, and go ahead and do it as a guest. And then you go ahead and just type in the letter and send. Okay, I thought it was supposed to give me a counter, but I don't know. So does it seem to be working for most people? All right. So I've never done this in such a big group, so I don't know if okay, there we go. We got some comedians here. Okay. So anyway, I'm just going to kind of move on. There's only a handful of questions in the presentation. So all right. So you already saw my disclosures. So in terms of an outline, what I'd like to do today is introduce some basics about asthma and asthma management. I know we've got learners at different stages here, so I want to make sure we're all on the same page. And then I'm going to turn my attention to sort of some of the new areas in asthma, talking about asthma phenotypes. And then finally, I'm going to tell you about a service that we have available here at the UW Hospital and Clinics, which is our Adult Advanced Asthma Care Clinic. So to start things off, just to give you an overview of asthma, it affects up to 10% of the population in all age groups. The incidence has been increasing over the past 3 to 4 decades. There are still 4,000 deaths per year despite the availability of some fairly effective therapies. And of all the patients that carry a diagnosis of asthma, estimates are that about 10% of them can be categorized as severe asthma. And I'll give you a better definition of severe asthma a little bit later. So this is a picture that we have laminated in our allergy clinic, and something that we use often when talking about asthma to our patients. And I think it's pretty clear to see that on the left side, we've got a normal, wide open airway that can freely move air. And then on the right side, you can see that the airway is severely compromised, and there's a significant inflammatory process going on in there. And one of the key things we often discuss with our patients is that this airway narrowing, this compromised airway, is something that can be very reversible. So there are triggers that can cause this inflammatory event to happen, and there are medications we can use to reverse this inflammation. So that's a key thing that our patients need to understand, is that this is something that we can clear up to a pretty significant extent and get them back to fairly normal airways. All right, so this is an overview slide of all the different pieces, I shouldn't say all of them, most of the pieces of inflammatory players that contribute to that inflammation in the airway. And I'm not going to go over each of the steps here, but I just want to highlight that there's a number of different cells that are involved. There are Th2 cells, so these are T helper cells that make a particular subset of cytokines. You can see up here IL-4, IL-13. There are eosinophils, which is one of the cells that I'm very interested in from a research perspective. And there are mast cells that are involved. These are cells that are central to many allergic inflammatory activities. And one of the things that's kind of depicted in this particular slide is that there's a lot of different inflammatory processes that are going on, and that the result of all of this inflammation affects a lot of other cells, so the epithelium, smooth muscle, and blood vessels. And we are now learning that that's not entirely true, and so I put on here another slide, which is really indicating that there are triggers, things such as rhinovirus, that primarily, as their first interaction with the system, is with the epithelium. And that the epithelium may actually be a driver of a lot of the inflammation that may be happening in the airway. And this particular slide is really kind of highlighting some of the newer cytokines that are being examined in the allergy world. So TSLP, IL-25, and IL-33. These are thought to be cytokines that are at much higher, earlier levels of driving the inflammatory process. And the rest of the slide kind of shows some of those same inflammatory cells that I just showed you in the other slide. And again, we've got the eosinophil down there and all this IL-5 that may be driving some of that inflammatory process. So I'm going to turn my attention now to management of asthma. So I put on here modern management concept. This is actually now over 10 years old, but we now really think of asthma in two different domains of control. So we think of an impairment domain, which is kind of the persistent impact of asthma on a day-to-day basis. And then we think of a risk domain, which are more of like the acute exacerbations that happen much more intermittently. So one of our treatment goals is obviously to reduce impairment. And this basically entails preventing the chronic and troublesome symptoms that may be experienced on a daily basis. We're going to try and maintain near normal lung function. We want the patients to maintain normal activity levels. And we want to minimize their use of rescue inhalers, so that albuterol that can provide immediate relief from symptoms. And then we want to meet their expectations of asthma care. And often this really entails making sure they're able to do activities that they're most interested in doing in their lives. The other aspect is to reduce risk. So we want to prevent recurrent exacerbations. We want to prevent loss of lung function, which down the road can be a risk factor for difficulties. And we want to prevent and minimize medication adverse events by optimizing the medications that they're using. All right, so here's one of the first polls. And again, if you're in asthma research or in allergy or pulmonary, I'm expecting you're going to know all these answers, so don't answer it. So this question is a 37-year-old female with a history of asthma starting in childhood. She's been able to manage with albuterol as needed. She's now coming to your clinic and is experiencing frequent shortness of breath and wheezing with minimal exertion. What's the best medication to start? All right, I'm just going to give you guys like 10 seconds. All right, so I think you guys, I probably don't even need to give this talk now. This is great. You guys all picked the right answer. Oh, okay, now we got some. Okay. All right, so the correct answer is C. In asthma, our first line treatment is going to be an inhaled corticosteroid. Part of the reason I put in this question is that the first two answers would be correct if we were talking about a COPD patient. So if a COPD patient comes in and you need to get them started on a first-line controller therapy, you could use something like a LABA or anticholinergic, long-acting anticholinergic. So those would be correct for COPD. But the answer for this would be Fluent. Advair is a combination, and that one ideally would be used in much more severe type of situations. So, but the first-line agent is often an inhaled corticosteroid by itself. All right, so some keys to management of asthma. So one of the things is to effectively measure and monitor asthma control. And I've kind of depicted three different pictures here. I'm going to start on the right side. So there's actually a questionnaire that we use in our clinic. It's called the Asthma Control Test. There's other types of questionnaires out there as well that basically consists of 5 simple questions that the patient can answer and can give us an idea of their level of control. In our clinic, we also will measure spirometry. And so for us, and I think for most most people that manage asthma primarily, use that as a vital sign. That's another one of the key measures that we want to follow. And then on the left side here are peak flow meters. And I have to say this is one of those things we don't use routinely. There are subsets of patients that really love having this kind of objective measure. We've actually found that a lot of times patients don't use it, and only when they're having symptoms will they use it. But just the fact that they're having symptoms, that alone is an indicator that they're not having adequate control of symptoms. But this is, again, something that some patients will request and certainly can be used to help assess their control. Another key for management of asthma is education and partnership. So it really does entail sitting down with the patient and making sure they understand what's going on in the airways. Again, that's where I use that picture to show that there's actually a lot of inflammation going on in the airways, and we need to reverse it. The other thing that we often talk about with our patients, especially the ones that tend to have a lot of exacerbations or difficulties with control of their asthma, is an asthma action plan. And I know you can't read all of this very clearly, but the idea behind an asthma action plan is that our patients are in a green zone of taking regular asthma therapy, and anytime they're having any worsening of their asthma, we will recommend some changes to their regimen, and that is the yellow zone. And then the red zone is basically if that yellow zone isn't working or if the exacerbation is very severe. And often this red zone is when we turn to use of systemic steroids. All right, the other key that we focus on is control the environment and comorbid conditions. So in the allergy clinic, we obviously spend a lot of time on potential allergic triggers to their symptoms. And then we also want to pay attention to things, particularly sinus disease and reflux. These often seem to be things that really complicate management of asthma. And then finally, we turn to pharmacological therapy, and we'll be talking more about that. Okay, so here's that asthma control test. I don't know if you can read all the questions, but basically, there are 5 simple questions. There's a scale from 1 to 5 where you can give an answer, and they give you little hints as to which one most reflects their levels of symptoms. And this is basically measuring what's happening over the previous 4 weeks. And we just simply add up the score, and anything equal to or less than 19 suggests that their asthma control is not where we want it. All right, so here's another poll. So have you entered or reviewed the asthma control test score for an asthma patient that you're following? Okay. All right. So so it looks like some of you are definitely kind of familiar with this, and the bulk of you have not. So I'm just going to tell you where you can find this. So the asthma control test is something we often will enter from the allergy clinic, and it's actually present in the flow sheet. And so hopefully most of you guys know how to navigate Healthlink and find where the flow sheets are. And all you have to do when you do the search, just search for asthma. If you just put asthma in there, you'll find it. And then it basically has a whole row here where you can enter the ACT score. Okay. And this is a patient that I follow in my clinic, and they had an exacerbation in January and is now finally on the mend. So this is where you can find those scores. So not only can you see the old scores, but you can enter new ones when you get into this particular sheet. All right, so I told you a little bit about the asthma action plan before. This is also something that's present in Healthlink. So my next question for you is, have you seen it in Healthlink? Have you used it or reviewed it with any of your patients? Okay, so this one looks like it's a little bit better than the asthma control test, but still about half of you that haven't. Okay, so this again is accessible in Healthlink. There is a tab on the left side along with all of these others that says Asthma Action Plan for patients that have asthma in their problem list. So if they have asthma in their problem list, this tab will appear. For me, I've customized all of mine so that it's automatically there. It's possible if you don't have it right there, you may need to go down below where there's that More button and can find the other areas or the other types of tabs that aren't there as your default. And you'll be able to find the Asthma Action Plan there. So when you come to that tab, you'll basically see the entry form for the Asthma Action Plan. And so this is where I go in and put in the medications that I want the patients using in their green zone. And then I don't have it here set up for me for this presentation, but if you just scroll down, there's an area for the yellow zone, and then further down is the red zone. So I can give all of those medications that I'd like for my patients to be on all in this particular place. Now, once I've finished the Asthma Action Plan, the thing I end up having to do is then go to the Letters tab and then select the Asthma Action Plan letter, and that will automatically import everything that was entered in those other fields and create a letter. Once I sign that letter, this Asthma Action Plan is now accessible to patient via MyChart. Okay, and for all of you providers, if all you want to do is see what the last Asthma Action Plan was, you can go straight to the Letters tab. So you don't need to go to that other Asthma Action Plan tab. But if you just go to the letters, you will typically see it's in the comments field. It'll tell you which letter is the Asthma Action Plan. You can go straight there and see exactly what our recommendations are. All right, so the medications you're going to see in the Asthma Action Plan there's a whole list of them that we now have available to us for asthma management. And so we have inhaled corticosteroids. Again, that's kind of our first-line therapy. We've got long-acting beta agonists. We've got combination medicines now, the ICS and LABA. We've got leukotriene modifiers. We've now got the FDA approval for the long-acting antimuscarinic agents. There are two other categories, which I've kind of shaded here, the mast cell stabilizers and methylxanthines. These were medications that were used much more frequently in the past and are not really in use these days. And then finally, we've got kind of our new cadre of medications, the anti-IgE and anti-IL-5 pathway medications. And these are some of the biologics, and I'll be talking much more about them in just a few minutes. The other thing to keep in mind with asthma care is that we often think about it in terms of a stepwise management. So you can have your patients on particular therapy, and based on whether they're having frequent uncontrolled asthma, or if they're well controlled, you can then either step up on their therapy or step down. And this is a figure I pulled from the NIH guidelines that were published actually back in 2007. And so it already gives you some guidance based on a number of different clinical trials on what would be kind of most appropriate add-on therapy to get to the next steps. All right, so this is a question here on a 48-year-old male with asthma currently using medium-dose Advair 250/50, one puff twice daily, and this patient is uncontrolled, experiencing nocturnal awakenings and use of albuterol rescue inhaler. And what can we do to step up his care? So we have options of increasing the Advair dose, adding on a LAMA, adding on Singulair, or any one of the above. Okay, so actually there's no wrong answer. You can pick any one of these. So the last one is the appropriate one, where all of these are now considered reasonable step-up management options for our asthma patients. And I just stuck this particular question in here just to kind of highlight that the latest addition to our armamentarium for asthma is the use of these long-acting antimuscarinic agents. All right, so how can we treat asthma better? And we are now kind of moving into an area of personalized medicine in asthma. In our asthma world, the first severe asthma biologic was omalizumab. It's an anti-IgE molecule that's really designed to block allergic inflammation. It was FDA approved back in 2003 for allergic severe asthma. It's dosed based on a nomogram that takes into account your weight and IgE level. So the criteria typically for using this medication is that the patient have severe asthma and have evidence of allergic sensitization. So I just wanted to introduce at least that one biologic. And this is a paper, it was published back in 2005, and it really, for me, was highlighting a very important concept that now we just sort of take for granted. This was a paper studying the use of inhaled corticosteroid versus Montelukast in a pediatric population. And what you're looking at on the y-axis is each of the individual patients. And along the x-axis, just to kind of simplify it, is basically a relative measure of whether they responded better to inhaled corticosteroid or Montelukast. So the patients all the way up on the top had a better response to the inhaled corticosteroid, and the patients on the bottom had a better response to Montelukast. And so this was like a very clear, basically indication that we have got heterogeneity in our asthma patients. There are definitely patients that are going to be better responders to inhaled corticosteroids, and others that are going to be better responders to Montelukast. And this was like a really great figure representation of this concept. Now, since that time, there's been a lot of work on asthma phenotypes. We definitely now recognize that not all asthma is the same. We've got a number of different types of research activities going on and trying to identify different categories of asthma. And so many of these are based either on clinical features or inflammatory features. This is a figure that was published back in 2006 by Sally Wenzel, and it was really based on taking into account some clinical and biological features. And so we've got this circle here, which is allergic asthma. We've got an eosinophilic corticosteroid responsive asthma. There's a severe asthma. It's kind of a mess. There's a lot of overlap between all of these, and it's still not really giving us a clear picture of what are some really good, distinct groups of asthma patients that we can actually act on. All right, so there have been, since that time, a number of efforts. There's a major consortium here in the United States that's funded by the NIH, the Severe Asthma Research Program, that's been kind of addressing this issue, and there's a European equivalent as well. In the Severe Asthma Research Program, they looked at 726 patients and took 34 sort of clinical variables, it's probably the best way to describe it, and fed it to a computer program and let it decide how many clusters of patients are there, how many distinct sort of subgroups of asthma patients could it identify. And that whole analysis, the whole statistical analysis, ended up identifying 5 different clusters. And each of those clusters had kind of some unique features to them. And interestingly, if you basically looked at their baseline lung function, their post-bronchodilator lung function, as well as age of onset, that would give you pretty good separation into those clusters. So this is one of the early, fairly rigorous efforts to try and help us identify some of the different phenotypes of asthma. Now, since that time, there have been attempts to try and sort them out even better. And that same Severe Asthma Research Program, in recruiting all those patients, was collecting not only clinical variables, but a lot of inflammatory types of markers and many other aspects of their asthma presentation. And in another analysis, this was a lower number, it was 378 patients, mainly because they didn't have all the variables for every one of the subjects. So with this smaller subset, they again did an analysis with now 112 variables. And when they did this analysis, they now identified 6 patient clusters. And one other interesting tidbit about this particular analysis is that they included healthy controls. The prior analysis mainly included only asthmatic patients of differing severity. Okay, so from this larger analysis of these patients, identified the 6 different clusters, and what I'm depicting here are different figures from the paper, and I'm certainly not going to go over each of these panels, but the sense I want you to get is that these clusters do have very different features. So one thing I'll kind of highlight is this panel right here indicates yes or no, have they visited an ER for breathing symptoms in the last 12 months. And so you can clearly see this cluster 6 has a very high proportion of the subjects in there that have gone to the ER. The first cluster has none of them going to the ER, and then you've got some intermediate amounts in between in those other clusters. Another one I think that really is pretty striking is this panel here, where the question was, have they had surgery to remove nasal polyps? So there's one cluster that basically has a very high proportion of them that have had polyp disease, and none of the other clusters really has any significant numbers of them. So these clusters are separating out our population, and they do have some clinical differences. So in a more recent review article trying to, again, depict some of these different asthma phenotypes, this one looks a little bit nicer now because you don't have as much overlap between a lot of the different areas, but one of the caveats is that even though we've got a lot of these nice, discrete, separate circles, they are overlaid on these polar variables. So we've got childhood onset asthma and adult onset asthma, and then you've got eosinophilic asthma and non-eosinophilic asthma. So all of these are still overlaid on those other features. But I think the sense I'm hoping you'll get is that we are identifying some of these different sort of phenotypes of asthma, and the big thing we have yet to do is to really identify what are going to be the best treatment options for any one of these specific phenotypes. Okay, so I'm going to turn my attention a little bit more to severe asthma. And so in terms of a definition for severe asthma, this is something even asthma experts had to come together and have a workshop to try and define. And that workshop basically ended up publishing this guidance in 2014. And I pulled the whole definition here for you, but basically the idea is that a severe asthma patient is someone that is either controlled on very high doses and maximal therapy, so they can be controlled, but require a lot of medications to maintain that control, or they can be using those fairly high levels of medications and have either poor symptom control, which we can, again, measure by some of those symptom assessments, frequent exacerbations, so we usually use a cutoff of 2 exacerbations per year to define it as being frequent, or serious exacerbations, so exacerbations that will land you into an ICU stay or get hospitalized, and then some criteria for airflow limitations. So kind of a number of different ways you can actually end up getting that diagnosis of severe asthma. And again, our sense is that of the entire asthma population, about 10% would fit these criteria. So these patients that have severe asthma, this has been a great focus in the asthma research world, because these are the folks that have the highest healthcare utilization. So they're seen frequently in our clinics. They have emergency department visits. They are the ones that end up having the hospital and ICU admissions. And they also have very high medication use. And that also brings in this whole arena of side effects, especially with high doses of steroids. So there has now been, and the main focus for my talk today was to talk about phenotype-specific therapy. And the idea behind this has been there for a long time. Back in 2000 and 2003, there were a couple publications on this molecule called mepolizumab, which is an anti-IL-5 antibody. And there were great hopes that this would now start giving us another tool to manage our asthma patients. And actually, I think there were some thoughts that we would be able to cure asthma with using this drug. And interestingly, those first 2 trials were completely negative. It did not work. And one of the things that was later realized is that these trials took all comers. So any patients with asthma were included in these trials. There were some hints in those trials that if we started stratifying some of our patients, that we might start seeing some signals. And so this was actually, this drug was actually revisited then in a selected population. And in 2009, there were actually 2 back-to-back New England Journal of Medicine papers that used a trial design where they only recruited severe asthma patients and then also made sure they were eosinophilic asthma. And in this one in particular, they had to have a sputum eosinophil percentage of more than 3%. And when they then restricted their recruitment to this population, now they saw a very clinically significant response. And what's depicted here is exacerbations. And so cumulative number of exacerbations on placebo is here in blue. And then for those folks on the drug, you can see there's about a 50% reduction. So this was a drug that was actually helping patients as long as we selected the right group of patients. So since that time, that drug was, the mepolizumab, was FDA approved. It's now 2 or 3 years ago. And now there are 2 drugs, that mepolizumab, as well as another one, reslizumab or Sincair, that are FDA approved and are both working by an anti-IL-5 mechanism, so blocking that particular cytokine. And there's a third one that's in the IL-5 pathway. It's called Fasenra or benralizumab. And that particular one is actually directed at the IL-5 receptor. So it has a slightly different mechanism. And it's also got another unique feature in that it invokes ADCC activity, so antibody-dependent cytotoxicity. So again, a very different mechanism than the other 2. So we already now in our asthma clinics are facing this big challenge of which of these biologics do we choose. And at least with these anti-IL-5 pathway medications, there are some logistics issues that play a role in which one we might choose. So just to let you know, the mepolizumab has a single dose that's given subcutaneously every 4 weeks. Reslizumab is medication that has weight-based dosing, but it's administered intravenously. So there are definitely patients that don't like coming in to get IVs. And that's administered every 4 weeks. And now benralizumab, which we don't quite yet have available in our formulary, hopefully in the next month or 2. This medication is also a single dose. Initially, for the first 3 administrations, is every 4 weeks. And then after that, it is administered every 8 weeks. And again, that's a subcutaneous preparation. The other aspect that we always will keep in mind, and I'll talk about a little bit later as well, is that some of these drugs have some additional indications. So for example, Mepolizumab has also now got FDA approval for use in Church-Strauss disease, which now goes by eosinophilic granulomatosis polyangiitis. Okay, so this is a question for you now. So what two blood tests will help with deciding which biologic medication could be used for an uncontrolled severe asthma patient? So this is something I haven't talked about yet, but your choices are an IgE and TSH level, a CBC to get the eosinophil count and an ANA, an IgE and the eosinophil count, or the TSH and ANA. I'm waiting for the comedians to answer. All right. So, okay, so everybody's getting this right. So an IgE and the eosinophil count, those are the two things that are going to, oh, yeah, there's that comedian. Okay. So the eosinophil count and the IgE level at this time, today, are the things that are most helpful to me to help kind of decide what therapies I might use. And I'm going to talk about our advanced asthma care clinic in a little bit, but that is the setting where we have really been using a treatment algorithm. And I fully confess this is sort of a simplification of it, but I think gives you a rough idea of how our approach is working right now. So that eosinophil level and the IgE level are the two main driving forces right now. And I'm just going to kind of walk you through this. So if there's somebody that actually does not have a high eosinophil level, that pretty much eliminates those anti-IL-5s as a viable option. And what we often will look at then is, do they have symptomatic atopic dermatitis? And if they do, we actually have an option to use Dupilumab. And I'll talk about this in a little bit. This has been FDA approved for atopic dermatitis, but there are also some great clinical trials, which I'll show you its efficacy in severe asthma. And so this is something we would use in a severe asthma patient that has symptomatic atopic dermatitis. On the other hand, if they have that high IgE level and not very high eosinophils, Omalizumab. So that's the one we've been using pretty traditionally, but that will still be something we can use in that patient. Now, these two middle categories are both categories where we have high eosinophils. If they have a high IgE as well, we can still think about Omalizumab. And there really isn't a great, at this point, just talking with my colleagues, we haven't got a great way to sort out, do we really want to use Omalizumab versus some of these anti-IL-5s? The one thing that does kind of come into play is how bad are their allergy symptoms or the allergy contribution. So if they do have pretty bad allergic rhinitis or seasonal type of symptoms, that might lean us more towards Omalizumab. But the other kind of question in both of these categories where we have high eosinophil counts is actually their BMI. So the reason for that goes back to that weight-based dosing. So one of the anti-IL-5s, the Reslizumab, has weight-based dosing. And so the concern always is that in our patients with a high BMI, if we don't use weight-based dosing, we might be underdosing our patients. And there's actually some literature that might support that. So if they do have a high BMI, we'll favor using Reslizumab. If they don't, we kind of then go to a patient preference issue. So both Mepolizumab and Benralizumab are subcutaneous injections, and there have been no head-to-head trials, so I can't really say with any confidence that one is better than the other. And so it becomes a patient preference of, do they want to come in once every 4 weeks or once every 8 weeks for the administration. So that'll help kind of decide things there. And now there's this other category where they don't have high eosinophils, they don't have high IgE. What do we do with these patients? This is an oversimplification. We do have some other things we think about in there, but one of the main kind of big gun options for these patients is bronchial thermoplasty. And I don't know if there's other pulmonologists that have talked about it at all, but this is a whole area of interest and an option for our patients, and I'm not really going to go into any more detail on that. And I know in the asthma community in general, there is a struggle right now to really understand what's the right patient to send for bronchial thermoplasty. All right, so getting to that non-eosinophilic severe asthma, so that's that area where right now bronchial thermoplasty may be the only thing that really seems to make sense. but there are many studies going on in this group, and I'm just going to mention a couple. One is the anti-IL-4 receptor. Again, this is that Dupilumab, and anti-TSLP. So the Dupilumab, this is a paper that was published back in 2016, and this is anti-IL-4 receptor. So it basically blocks the activity of two very prominent Th2 cytokines, IL-4 and IL-13. And what's depicted in this figure is, in the top panel is eosinophilic asthma, and this is non-eosinophilic asthma. And you've got two different doses with two different sets of intervals. So I apologize, there's just a lot of bars here. But I think the sense that I really want you to take away from this is that, well, first of all, in eosinophilic asthma, your rates of exacerbations are higher than in non-eosinophilic asthma. I don't know if I had mentioned that to you before, but that's something that shows up quite a bit in our research studies. And when we use Dupilumab, we get some significant reduction regardless of the dosing and the intervals. So again, these are 4-week intervals, 2-week intervals. But the interesting thing is, even in non-eosinophilic asthma, we are seeing some impressive results. So it seems to be working even if you don't have an elevated eosinophil count. It seems to work better if you do have an elevated eosinophil count, but this other population may benefit from it as well. All right, the other drug that I'd mentioned is this anti-TSLP, so Tezepelumab, and this, again, this is basically showing rates of asthma exacerbations, and looking at placebo versus, I believe this was different doses of the medication. And they've stratified it by having low eosinophils or high eosinophils. And this one, I think, is much more straightforward in that the results are almost identical regardless of what the eosinophil count is. So this may be a treatment option that may work very well regardless of whether you have eosinophilic asthma or not. All right, so those two drugs, those last two that I mentioned, have not yet been FDA approved for use in severe asthma. And we are expecting that they will get approval probably within the next, I think Dupilumab is going to be fairly soon. The Tezepelumab is probably a couple years away. But once we have all of these drugs available to us, we are going to be in a quandary. We won't know which one of these drugs to actually use for our patients. And this is something that the NIH has already kind of recognized, that we're going to have a lot of options, and we really do want to try and provide some good guidance as to what is going to be the best approach to take. And so the NIH has set up a network. It's the PRECISE network, and so this is a network for precision interventions for severe and exacerbation-prone asthma. And Dr. Denlinger is the PI for our site. And their goal is to basically establish an algorithm or criteria to basically provide a precision medicine approach to managing severe asthma. And so it's really going to be the results of this trial that are going to provide some very important guidance to us once we have all of these different therapeutics available to us as to where we might want to go with next. One of the interesting things, and I think Dr. Denlinger is going to probably talk about this at a grand rounds down the road, but one of the nice things about this trial is it's an adaptive trial. So people that start down one pathway will then get shuttled into some other pathways and kind of provide a more realistic approach of how we may see our patients. All right, so I did have another poll in here. So you're seeing a severe asthma patient who is continuing to have exacerbations on current medications. You remember this grand rounds that I gave about medication options. What do you want to do next? Okay. All right. So actually, I'm not sure you can even do that right now. I don't know if it shows up. I'm still waiting for that comedian to show up here. Okay. So actually, the first three are what I really want you to do. You can actually do any one of those, but don't do D. The Adult Advanced Asthma Care Clinic, at least my understanding right now in Healthlink, I don't think you can directly consult into it. That's my understanding. We do want to change that once we, I'll talk about that clinic in a little bit, but that's something that we're going to want to have you be able to do. But right now, I think I have it in the next slides. Yeah, so we'll kind of talk about it. So I want to kind of segue into this adult advanced asthma care clinic that we've set up. So what is this? It's a multidisciplinary clinic. We've got allergy attendings and pulmonary that will both see the patient on the same day. So this is a 2-hour appointment. We also include visits with pharmacists as well as nurse practitioners. So we've got allergy nurse practitioners and pulmonary nurse practitioners that are involved. So it's a very long visit, meeting a lot of different people, and we get input from each of our areas, and we end up doing this huddle. And I think that's supposed to be a big concept in primary care as well, where we take all of our evaluations and put it together and try and come up with a comprehensive game plan. So our goals are to come up with an asthma action plan for the patient, provide additional education on their disease. Another big area is on their medications. I don't think I mentioned it before, but as you may know, these inhalers that we have all different types of mechanisms, and so it can get tricky how to use one inhaler versus another. Some of them you can benefit using a spacer, some of them you can't. So these are issues that can often be confusing to patients, and we need to make sure they understand their medications. And kind of talk to them about management of symptoms, and then also establish some clear follow-up. So when is this clinic held? Right now, we are holding this clinic a half day every month. It's usually on a Friday morning. We are already kind of contemplating increasing the frequency of this clinic, but have run into some difficulties with staffing and finding space and things of that sort. Where is this held? Right now, it's actually being held in the pulmonary clinic, so right here in the hospital, in the UW hospital in B62. Who are the people involved? So right now, myself and Dr. Wiswanathan are the two allergy attendings, and our allergy nurse practitioner, Mary Love Patton. On the pulmonary side, Dr. Denlinger is involved, and the pulmonary nurse practitioner. And then we've got a number of different pharmacists. Christina Yokes, Tim Ye, and Vanessa Grappus have been involved in this whole project. So who are we targeting? We're really targeting those patients that have been hospitalized for their asthma or are having frequent exacerbations. So again, getting back to our severe asthma definition of requiring more than 2 courses of corticosteroids in a year. So these are the folks that we feel may benefit the most from being seen in this kind of multidisciplinary clinic. And so this is the thing I was trying to, I was kind of alluding to before. So how does a patient actually end up into this clinic? So if you do a referral to allergy or pulmonary, and again, right now I don't think you have access to the adult advanced asthma care clinic, but if you do a referral to either one of those other clinics, our front desk staff will automatically take a look at some of the history and determine if they've been hospitalized or determine what their frequency of exacerbations are, and will automatically convert it to a referral into this clinic. So we're trying to make all of this very automated. All right, so just to kind of summarize, asthma control can be monitored by assessing their impairment and risk domains. And again, you can use tools that are available right in our EMR. Guideline management can be very effective for a majority of patients by using the different steps of care. We, in Healthlink, can already record the asthma control test, and for many of our asthma patients, unfortunately I can't say all of them, but for many of our asthma patients, they do have an asthma action plan. So if you're curious what we in our allergy clinic or in the pulmonary clinic have really wanted the patients to be on, look at that letters tab and find that asthma action plan. And we already are starting this patient and phenotype-specific therapy. And it's going to get more complicated in the future, but we have already started down that path. And I just wanted to, again, remind you, we've got this adult advanced asthma care clinic. And if you do feel anybody needs to be in that clinic and didn't get automatically referred, obviously contact myself, Dr. Wisconsin, or Dr. Denlinger, and we can easily make sure that happens. And with that, I'll take questions.
Thank you very much, Dr. Mathur, for a very wonderful talk. It's open for questions, so please raise your hand, Samir, call on them, and please repeat the question.
Okay. All right, Bill.
Samir, nice job. And looking in your crystal ball, biologics, for some people, have had dramatic effects. Do you see 5 years from now our shift away from inhaled steroids and long-acting antibiotics to biologics in the right person, in the right
Yeah. So Bill asked me to look into the crystal ball and what do I see the role of biologics being down the road. And, these are discussions I've had with a number of people. I mean, if you look at what has happened in the rheumatology world with some of the TNF inhibitors, they initially were very restricted in terms of their use and now are being used much more broadly. My suspicion is the same thing's going to happen in asthma. So right now we're talking about all of these biologics being used in very severe, the most severe patients. But down the road, I think, especially if we start identifying a lot of these subtypes of asthma that will very specifically respond to the anti-TSLP or Dupilumab or something of that sort, we may start using these in moderate asthmatics and much more milder disease where they may not need inhaled corticosteroids. So yeah, I definitely, I don't think it's going to be 5 years, but it'd probably be a little bit longer than that, but I think that's a very reasonable approach.
Dr. Mackey?
So Dr. Mackey asked a couple questions. So asking about sort of more global, like microtrips and genetics to see if we can kind of categorize. And then is there a chance that down the road these biologics may not work? So at least with that second question, all of these antibodies that have been developed, and I think this is true for most of these types of biologics, they're all humanized. And so the thought is that the risk of having antibody responses to these is going to be fairly low. So I'm hopeful that that's not going to be an issue, and I guess I haven't really looked into the TNF inhibitors. Obviously, have been at a much longer time out there, and I don't think that's been a big issue there. So I'm hoping that's not going to be the case with the asthma medications. And then regarding your question about genotyping and microarray and stuff, these big network studies, so the SART program, as well as again, there's a whole European cohort. There are a lot of omics that are being done right now in asthma. So the transcriptomics in the sputum. There's certainly all the genetic information. The microbiome is another big one right now. So there's a lot of omics that are being looked at. I didn't include. So one thing I did not include in my talk at all is that there's also this whole notion of asthma endotypes, which are based on a lot more of the biology of what's going on. And that is not ready for the clinical realm yet. That's still very much in the research arena. And there's hope that those will provide much more specific information about individual patients. So there's a lot of other people that could probably answer this better than I could here, but yeah, I mean there's a whole neutrophilic asthma group.
Comment on the question.
Oh, I'm sorry. So the question was when I put up that treatment algorithm all the way on the right, I had this group that had low EOs, low IgE. And is that like an outlier group? Is it really asthma? What do we know about that group? So that definitely is an area of interest. And the thought is that there are other inflammatory mechanisms that are really driving what's happening in terms of the inflammation in that group. The interesting thing is that I think some of the antibodies that we're using, like the TSLP, that may be something that's so high up in the signaling cascade that it may help that group as well. But there are different inflammatory mechanisms. I think the neutrophilic asthma is something that kind of falls more into that. If we think more about the endotypes, there's a whole class of Th17 driven asthma that may be a part of that group. So yeah, so there is definitely different pathophysiology. We suspect we're going to use very different biologics to try and help that group. So the question was regarding some of the slides I showed referred to a sputum eosinophil count, and others referred to a peripheral blood eosinophil count. And there's a high correlation between the two, and so that's why in many instances we will use them somewhat interchangeably. The big issue is that we think it's the sputum eosinophil that's really doing all the badness in the airway. That's a very difficult thing to measure. It's not something a general allergist out in the community or pulmonologist will be able to do very efficiently. And so there's always been the search for what's another biomarker that might represent and give us an idea what that sputum eosinophil count is. And the peripheral eosinophil count has actually been a pretty good correlate. So our assumption is always that if you've got that high peripheral count, it's very likely you're meeting the elevated sputum count as well. Yeah. Oh, yeah. No, so that's a great question. Okay, so the question is about the cost of these medications and how that, I guess this all was spurred from a bioethics type of symposium. So just so you know, these biologics, the cost is somewhere in the neighborhood of $36,000 a year. And I think we had initially thought that with more and more of these coming, that the cost would actually go down. But it's not. Actually, every new one that comes is targeting that exact same price. And so, I'm hoping that now we'll have two other agents coming out within the next few years. At some point, there's got to be some competition going on that might help drive some of these costs down. But right now, it hasn't. Now, one of the reasons why these medications are only being restricted to the most severe asthma patients is they're the ones that are getting into the ICU, that are having the ER visits. And so there's a good justification for, we are, in the big scheme of things, actually saving money by using some of these biologics. So, I think once, if the cost became much less, I think this kind of gets back to Dr. Bussey's question. I think if this becomes affordable, and if we're the same price as an inhaled corticosteroid, this would be a much better approach to take. So the question is about titrating the dose of some of these medications, and if we have a treatment failure, what do we do at that point? So as far as the dosing, again, we basically have sort of set dosing, especially for the mepolizumab and benralizumab. Reslizumab is the one that has the weight-based dosing, but that's pretty much static. Now, having said that, there have been some instances where we've been able to increase the dose. It's not something insurance or even our pharmacy really wants us to do, so it's a lot of headaches to try and do it. But it is something we've done on a few occasions. And as far as using one of these and then having a treatment failure, so actually dose ends up being one of the issues that does drive us to potentially go to a different agent. So I think the best example is with mepolizumab. If we have a treatment failure there, we very strongly consider moving over to reslizumab and using weight-based dosing to see if that may benefit patients. And I personally haven't done that. We've definitely considered it. I tried to do it for a patient, but the insurance wouldn't cover it. But my colleague, Dr. Viswanathan, has done that successfully on a couple occasions, I think.
Thank you very, very much, Dr. Mathur, and a wonderful talk.